So what is oscillometry? Let me just start off first but to say that it is not a traditional pulmonary function study. It does not require patients to blow out forcefully. It doesn't require to do them any specific maneuvers other than to breathe normally during the assessment. It also doesn't measure flow and lung volumes in the same way that what we're used to. What it does is that it actually superimposes uh, oscillatory pressures of different wavelengths on top of the patient's normal quiet breathing. And what we measure is actually the changes in the waveform as a result of this. And through signal processing, what we're able to then do is actually do some, to actually get measurements of respiratory mechanics and the breathing pattern of the patients. And this is perhaps a little bit better illustrated in this slide here. So what we're doing here is imposing wavelengths or pressures of different wavelengths to the patient's normal breathing pattern. And what we measure at the end of that are changes in the pressure and the flow. And through this, we're able to get to do the signal processing to get the information that we need to assess respiratory mechanics. And what oscillometry does is it takes advantage of the different properties of the wavelengths so that the higher frequency wavelengths, the frequencies that are in the 20 hertz and higher frequencies, are able to traverse, but only traverse into the large airways and the medium-sized airways, whereas the lower frequency wavelengths, those that are in the 5 to 11 hertz range, are able to travel much further down into the lung and to reach the lung periphery in the small airways. And it is through this partitioning of the analysis of the impedance of these pressure waves to flow through the lung that we're able to then assess the different regions of the lung with respect to its mechanical properties. And it is specifically this exquisite sensitivity to the lung periphery that had made it very useful to the respiratory physiologists for the past half century. The lung periphery in the small airways is a region of the lung that is not well assessed by conventional methods. And the other aspect of oscillometry that has made it sort of more popular, if you will, is the fact that it's conducted under normal tidal breathing. So you can do it on really young children, you can do it in elderly people. As long as that person is able to breathe, they can do oscillometry. And it can also be done, obviously, in people where spirometry and body box measurements are contraindicated. Now, in the last 5-7 years, there has really been an explosion of publications that have looked at oscillometry in evaluation of lung function, particularly in the obstructive lung diseases. And it's pretty well accepted now that oscillometry is superior to conventional pulmonary function studies in terms of its ability to correlate with symptoms and to predict exacerbations of COPD. There has also been a number of studies that have shown that oscillometry is better than spirometry in early diagnosis of COPD and therefore potentially for better management of COPD by allowing for earlier treatment. Now, my group began our studies in lung transplantation in late 2017, where we prospectively enrolled patients who were just transplanted to oscillometry in comparison with spirometry. And the specific endpoints that we were interested in looking at was biopsy-proven, clinically significant acute rejection and comparing those to biopsy-proven no rejection. And the comparisons that we were interested in looking at was a comparison with the current gold standard method of monitoring lung function, which is FEV1, with the oscillometry parameters of R5 to 19, AX, and X5. This paper was published in the Blue Journal in June this year, and it was accompanied by an editorial. And I'm forever grateful for Dr. Usmani, whom I hadn't met at that point, because not only did he provide us with the editorial, but he actually provided a primer to the readers in terms of how to interpret pulmonary functions, to interpret oscillometry. And this diagram here is an oscillogram that I have copied from his editorial. And what you see here is that what oscillometry does is that it actually partitions, or it segregates the measurements of respiratory impedance into the values of resistance, which is shown here in the blue, as it is plotted against the different frequencies at which oscillometry is measured. And the other metric that is used is the reactance value, again plotted against the frequencies at which we measured. Now, if you were to take the lung as a single compartment model, it turns out that the resistance value is a metric of the airway caliber. So the narrower the airways, the higher the resistance. The second aspect, this reactance value is a metric of the tissue elasticity and the capacitance of the lung. So the soft stuff, the parenchyma of the lung. And the two metrics, just keep in mind as I talk and go through the next couple of slides, are these two metrics shown in red here, the R5 to 19, the difference between the resistance at 5 Hertz and the resistance at 19 Hertz. It is a metric of small airway function, and so the more small airway obstruction there is, the higher the R5 to 19. It is also a measure of the inhomogeneity of ventilation in the lung periphery. The second value to keep in mind is this area, this thing called the AX, or the area of reactance, that is shown here as the area under the curve. It is a metric of the elastic properties of the lung and of, again, inhomogeneity of ventilation. The higher this value goes, the stiffer the lung and the more inhomogeneity in terms of ventilation. And these were the metrics that turned out to be highly significant in patients with acute rejection. So if we were to look here at these patients with acute rejection, shown here in the red, and compare that to patients with no rejection in blue, what you see is that on the week of the biopsy, there is significant differences between the R5 to 19, between rejection and no rejection. More remarkable, though, is the fact that these differences were beginning to be evident the week before the biopsy, before the diagnosis was made. We see the same pattern with the AX value, so that this was significantly higher in people with acute rejection versus those with no rejection. Again, this was seemingly evident the week before. In contrast, if you were to look at the FEV1, what is still the gold standard monitoring metric for lung function post-transplant, what you see is that in these red patients, the patients with acute rejection, you would have actually thought that they were getting better because it looked like their FEV1 was actually improving. The other thing that we noted was that once the patients had been treated for their acute rejection, what you saw was that there was a reduction or improvement in the lung mechanics. So a reduction in the R5 to 19 2 weeks after the acute rejection episode. Most of the patients would have been treated sort of around 7 days after the biopsy results, after the biopsy occurred, because that would be when we got the results back. We see the same thing here, that the AX also improved, dropped down to actually values that were very comparable to patients who had no rejection. And again, if you were to just look at the FEV1 values in in these patients, you would think that these patients were doing really well. And in fact, if you come from a center where routine transbronchial biopsies are not done, you would have missed these episodes of acute rejection altogether. And so what we concluded from this study was that oscillometry, and specifically the measurements of R5 to 19 and AX, tracked graft injury that was associated with acute rejection and was able to track its recovery after treatment of acute rejection. From the point of view of where oscillometry could fit in terms of general respirology, I think that it has an excellent role in terms of screening for lung disease, in any setting where there's a high potential for underlying unrecognized lung disease. And it likely has a role, in fact, I know that it has a role in speaking with colleagues in the management and follow-up of patients with asthma and COPD. The take-home message for today is that oscillometry tells you that there's graft injury. And we don't get that information always. In fact, we usually don't get that information from spirometry until it's a bit too late.